Deepshri. I'm currently a senior resident in a medical college in Dehradun. Okay, so my presentation is about LMA device and TP's device. Next slide, please. So, laryngeal mask airways are basically supraglottic airways that were invented by Dr. Archie Brain at a London hospital. They started being used in pediatric side from 1990. It basically consists of two parts, a mask and a tube. And the laryngeal mask, basically, it provides an overseal over the laryngeal inlet once the LMA is inserted and cuff is inflated. So here we see a LMA. So it consists, the mask can be seen. The mask has a inflatable cuff that is present around the mask. So once inserted, this cuff has to be inflated and which will keep the LMA in place. Next slide. So they come in various sizes. The sizes that are recommended for neonate is size 1. However, different companies have different sizes. So mostly size 1 is recommended. Some LMA 0.5 size is also available. So they are recommended for any children that is born that is less than 5 kgs and is over 1.5 kgs, 34 weeks or more of gestation age. In less than 34 weeks and less than 1.5 kgs, LMAs, there is not any good evidence for the use of LMA. Next slide. So these are the different companies from which the laryngeal mask airways are available. IGL airways are usually the airway that is recommended for use for in neonates. Next slide. So the technique of insertion is that we usually guide the mask side. The open side has to face the chin of the baby, and the closed side faces the nose. We guide the airway into the baby's mouth using the operator's index finger, and then once inserted, we'll feel a resistance. At that resistance, is usually the laryngeal airway will sit over the laryngeal opening. And at that time, the cuff has to be inflated and the laryngeal airway is in place. So once inflated, the laryngeal airway also usually will occlude the esophagus with the low pressure seal. Next slide. So here we can see the technique of placement of the laryngeal airway. So with the two fingers, it is guided along the along the chin of the baby, and once in place over the laryngeal inlet, it is inflated. Next slide. So LMA, the first role is in the neonatal resuscitation. So it was first introduced by the AAP and the AHA as in 2000 guidelines for neonatal resuscitation. Firstly, it is recommended for as a part of the primary ventilation. So whenever there is ineffective face and mask ventilation in neonates because of abnormal facial anatomy, unstable cervical spine, and upper airway obstruction, it is in those places LMA can be inserted and can be used. So in some current studies, LMA has also been recommended as the primary device to be used for neonatal resuscitation. So instead of face mask, we at the initial start of the neonatal resuscitation only, we'll insert an LMA and start positive pressure ventilation using an LMA. Second thing is, it is also recommended in place of the ET tube when, if suppose because of some reason we are not able to intubate the child, we can place a laryngeal mask, and with the laryngeal mask, we can continue the neonatal resuscitation, including chest compressions can also be given. So LMA is recommended in late preterm, that is more than 34 weeks, in full-term newborns and newborns with a birth weight of more than 2 kgs. Some studies say more than 1.5 kgs. So other uses is like even emergency drugs such as intratracheal epinephrine can be given. There's lately laryngeal surfactant administration through laryngeal mask and other supraglottic airways has been used. So in this thing, what we do is we put a laryngeal airway, and using a laryngeal airway, then the surfactant, like once the laryngeal airway is in place, we'll use a catheter to instill the surfactant into the baby. And positive pressure ventilation can be given with the help of the LMA. Once positive pressure ventilation is given for 5 to 10 minutes, then the laryngeal mask airway is removed. Other uses of LMA includes neonatal transport of babies with difficult airways, and in settings where the lack of operator skill may prevent adequate ventilating assistance. The potential complication associated with LMA are there could be gastric distension, vomiting, and regurgitation, and stridor. Local soft tissue trauma due to the seal, difficulty in suctioning as it actually occludes the esophagus also, and an improperly placed LMA can lead to partial airway obstruction and which can lead to breath holding. Coming to TP's devices, TP's device is basically a device that is used for providing positive pressure ventilation during resuscitation. So in NRP, it along with a self-inflating bag and a flow-inflating bag, it is recommended for delivery room CPAP. The benefit is it provides a more controlled method of ventilation compared to simple valve mask ventilation. So the components include an inlet port for the oxygen supply, which is regulated by a flow meter to control the oxygen concentration. The outlet port is connected to a face mask or an ET tube or any other airway agent, including a LMA. The pressure manometer is used to monitor the pressure being delivered to the patient. So the PEEP valve can be rotated to modify the PEEP provided, and occlusion of the PEEP valve actually can modify the PIP delivered. So the initial recommended settings is usually the gas flow rate is set at 10 liters per minute. If we are using an oxygen cylinder, we usually set it at 8 liters per minute. Maximum pressure relief valve is set at 40 to 50 centimeters of H2O, and PIP is set at 30 centimeters of H2O in a term baby and 20 to 25 centimeters of H2O in a preterm baby. PEEP is set anywhere between 5 to 8, and it can be modified as we give the positive pressure ventilation. So main advantage is the delivery of inflating pressures which are closer to the predetermined target pressure with the least variation. So when we are giving the PPV, we can see it is reflected on the manometer what pressures are being delivered. And it can also provide the prolonged inflation breath. So the length of the inspiratory time can be changed by varying the duration of the occlusion of the PEEP gap. And thus more consistent tidal volumes are delivered. Disadvantage include it requires a gas source to operate. So if we do not have a gas source, we cannot use a PPV machine. In that scenario, a self-inflating bag is the best thing we can have. It is a more it requires technical. It's a more technical, more difficult setup, because once we have set a machine, we need a we need to determine if the machine is working or not using and more time is required to adjust the pressures during resuscitation, and less ability to detect the changes in the compliance. Thank you.
Thank you, Deepshri. That was very wonderful. You said you are a junior resident in a medical college in Dehradun?
So I'm senior resident.
Oh, fantastic. And which is this the HIMS hospital or no? Which medical college is this?
So it's SGRR.
Okay, good.